This next section is really about highlighting some of our successful SPI sites. Atlanta is an innovative approach to public health that's in collaboration with their local hospital as well as some community policing efforts. The Brighton and Commerce City, Colorado site is a sexual assault task force that they've been working on for the last 2.5 years. St. Louis developed some mobile surveillance trailers that helped expand their technology reach in areas that didn't have infrastructure build outs, and they're using these to help reduce violent crime. And then the Providence team is a co-responder model that is pairing mental health experts with the police that are proactively working with individuals that were highly utilizing various emergency services in Providence. So the goals of this session are to hear about how they've kind of worked through their SPI. All of these sites are in the second or third year of their SPI awards. When we highlight these and say that they're highly successful SPI sites, I want to emphasize that this doesn't mean they haven't had their challenges along the way. I think each of the sites that we hear from today faced either, actually, I think a couple of them were facing some HIPAA requirements that they had to navigate over time. But also there's some other challenges that they faced in terms of data, in terms of organizational buy-in at various stages. And we just wanted all of the new sites to be able to hear from these experiences and hopefully take something away as you're either thinking about the kickoff of your SPI or now that you're in the first year of your implementation of your SPI. With that, I think I'm handing it over to Shyla and Jasmine. Start off with Atlanta.
Yeah, hi. Thank you to CNA for organizing and hosting this meeting and inviting my colleague and I to talk about the Atlanta SPI, which we refer to as the Program to Interrupt Violence Through Outreach and Treatment, or PIVOT. Ms. Moore, who you'll hear from later, is a public health expert with Grady Memorial Hospital in Atlanta, where she's the Violence Prevention Coordinator. And I'm Shyla Hawk with Applied Research Services. I'm the SPI research partner in Atlanta. First, we'll provide a little bit of background and context, then discuss our approach to how it evolved and cover some of our outcomes and success examples, and then conclude with lessons learned and insights. Throughout the presentation, you'll hear how some of the key SPI principles were operationalized: strategic targeting, use of intelligence and data, performance measurement and research, managing and sustaining operational change, and outreach and collaboration. So Atlanta city limits is about 500,000 residents. Its metro area, however, is around 6 million and counting. It has a nearly 2% annual growth rate, which makes it the fourth fastest growing city in the States, and we have one of the most diverse populations. Unfortunately, when we started the SPI, we also had a violent crime rate about 3 times the national average, 1,100 incidents per 100,000 residents compared to about 400 nationally. Tasked to respond is the Atlanta Police Department, or APD, and they have an authorized force of 2,000 officers. That's been difficult to achieve those, and currently we set around 1,700 sworn. APD operates within 6 zones and the airport, a 137 square mile jurisdiction, of which, and like many other cities, there are hotspots of crimes, areas in the city that have been blighted by gun violence, among other significant challenges. Also responding to incidents is Grady Memorial Hospital, which we refer to as Grady, and they are the PD's primary collaborator on the SPI. They are the largest level 1 trauma center in the city and thus intersect with APD regularly. Gun violence isn't a new issue for Atlanta. However, its pervasiveness and rapid growth was alarming to multiple stakeholders when we started the SPI, which included those working in the criminal justice system and medical service providers. So the nexus between the two fields demanded a collaborative response. Crime had declined in Atlanta, yet the risk of gun violence had increased. Residents were about 1.5 times more likely to experience a shooting. Consequently, the goal of PIVOT is to interrupt the retaliatory contagion of violence that it can occur after a single event. In fact, shootings in Atlanta had increased 65% in 5 years. We examined multiple sources of police and hospital data to understand the problem, particularly related to differences in gun crimes. We used incident reports, Part 1 crimes with guns, shootings, fatal and non-fatal, gun seizures, guns stolen. We looked at calls for service, shots fired, person shot, and we analyzed hospital data, both visits and injury admissions. The data told a clear story. Victims were primarily minority males living in a small geographical area. It also revealed that people do not necessarily report to both police and hospital. So there were gaps in the data that we typically use to understand and address the risk and protective factors related to shootings. What we do know is that after a single shooting, the likelihood of a recurrent gun violence event, retaliatory or hospitalization, can be as high as 45%. These incidents cost billions of dollars to our medical and criminal justice system, and that doesn't calculate the toll on families and communities. Therefore, the basis for the Atlanta SPI approach was to address the issue of gun violence as a contagion through a coordinated public health model, which acknowledges that gun violence can spread like an epidemic through social interactions and personal networks. A three-pronged approach, or the socio-ecological model, was adopted in Atlanta because research shows that for meaningful change to interrupt persistent issues, we must address the associated and interconnected persons, places, and policies. At the person level in Pivot, patients are met by crisis intervention specialists who provides mentoring and then uses that relation to identify and connect shooting victims to service providers. Dedicated APD officers work at the neighborhood level in communities doing focused oriented policing, building collective efficacy, responding in the aftermath of shootings to calm and liaise, and help identify and connect communities to services. And at the macro level, the partnering agencies adopt evidence-based practices to support intervention efforts and make decisions based on data and information sharing to continuously monitor and improve the approach. I'll now turn it over to Ms. Moore, who will provide further detail on the Atlanta implementation. Thanks.
Thank you, Dr. Hawk. So one of the very first things I want to highlight falls under the SPI principle of outreach and collaboration. We will actually talk about this principle often as it can be central to initiating and sustaining the innovations of any SPI. Dr. Hawk mentioned the nexus or intersection of service and interaction with individuals and communities experiencing high levels of firearm-related crime and violence. Identifying this was a catalyst for bringing partners together. We started with multiple potential stakeholders at the table before we developed a clearer vision of our multi-level public health approach and facilitated the regular meeting cadence of the Pivot Task Force. This task force is made up of representatives from APD, Grady, the Criminal Justice Coordinating Council, our fiscal partner, and Applied Research Services, our research partner, and community-based service providers. This team met monthly for the purposes of identifying enablers and barriers to implementation, set goals, and explore opportunities for sustainability. We were often and more consistently joined by representatives from agencies that were shaping up to be longer-term partners. Some of the core innovation in our approach lies in addressing the issue of gun violence across sectors, which implies those outside of law enforcement and healthcare. These meetings were helpful to that end, as we had the opportunity to explore how our efforts as an SPI were bumping up against or supporting other violence prevention efforts. The top opportunity I want to emphasize here is that regular engagement with your key partners, collaborators, and staff should serve as more than just a report out. This can and should be a space of relationship building and maintenance. The design of this is important and should include an agreed upon approach to governance and decision making. It is through these conversations that differences and alignment in organizational culture and sector language can be identified and addressed. For every way that trauma centers and police departments are different, they're similar. A focus on relationships and the overall health of your collaboration is valuable here, especially so in our case, as the task force representatives were more dynamic than static at times. Dr. Hawk assessed our collaboration quarterly and helped us to identify and address shifts in morale, among other things. As it pertains to the principle of performance measurement and research, we took an iterative approach. One of the challenges of innovation can be the unanticipated roadblocks. Even our thoroughly informed blend of evidence-based practices hit speed bumps. These speed bumps were identified and addressed as promptly and effectively as possible through an iterative approach of scanning to identify the problems, analyzing them, through information gathering, responding through informed decision-making and solution implementation, and assessing that response through the continued and strategic monitoring of problems. This process was continuous for us, and essential to it was establishing our definition of success, how we would measure it, and setting baselines for each area of implementation we wanted to see success. The same goes for measuring how we might identify barriers to the process, even if the measures were not directly related to our definition of success. And our response to these items contributed to our evolution of the program overall and informed new practice. One example of this includes our identification of the limitations of surveilling firearm-related injuries in healthcare. Inconsistencies around documentation and coding rendered our original clear-cut strategy to screen patients incomplete. We analyzed to understand all of the contact points clinicians have with gunshot wound patients and responded by developing an approach that combined or pooled a few existing ways of identifying patients. Our assessment of this solution was that it was ultimately still incomplete, but also proved to be the most comprehensive capture of gunshot wound patients that existed in the trauma center. This has since informed a publication on the limitations of diagnosis codes and the implementation of an additional program at Grady that serves victims of violence. Hitting obstacles, of course, was not the only way in which the Atlanta SPI was driven to evolve. Having a stellar research partner kept our implementation information-driven and helped us to avoid guesswork. Every stage of developing and implementing the SPI was guided by information, more often than not, gathered and analyzed by Dr. Hawk. In the way of using evidence-based practice to guide us, we had the benefit of participating in a peer exchange with a long-established hospital-based violence intervention program in San Francisco. Their implementation is seen as one of a few gold standards for evidence-based practice in this space. However, we did not seek to replicate their exact methods, but to learn from them by understanding the similarities and differences in design, capacity, and scope. No other hospital-based or linked programs collaborate with a law enforcement partner like the Atlanta SPI. Other sites on the West Coast and in the Northeast have easily more resources or local and state level buy-in than we did in Georgia. The peer exchange and knowledge of evidence-based practice was just as much about learning what is yet to be done as it is about what to do. This sets the tone for understanding how your SPI is innovating and contributing to the knowledge base of best practice. On the law enforcement side, we received technical assistance and essential guidance from Craig Uchida to help our team and officers better understand collective efficacy and attempt to visualize implementation of those approaches in our target neighborhoods. Growth and expansion were major contributors to our evolution. At the community level, we sought not only to understand our impact through engagement with residents via surveys and meetings, but also to understand gaps in services and partnership that could be filled through the development of a community resource network. Who is missing from the table based on what the residents are saying they want and need? How do we fit into that? And as I described before, iterative surveillance of our implementation through setting baselines and understanding our scope and goals were key to our evolution. A few examples of this include the use of RMS and CAD data to identify potential target neighborhoods for the officers to work in, but consistently assessing the feasibility of working in those areas and modifying appropriately. In the hospital, we started with only 3 zip codes of residence or injury that we would enroll patients from. After a pilot period, we revisited the list of patients that had been screened ineligible and looked at the next most frequently occurring zip codes of residence or injury and used that information to inform expansion of eligibility to those areas when we were agreed that we had the capacity for a higher volume of patients. Having base measures and a continuous system of monitoring really helped us grow. And even if it wasn't always perfect, we have quantifiable lessons learned that will inform new practice. The Atlanta SPI has done really cool work. In the area of outreach, we sustained cross-agency work for all years of the project. Some of the partnerships I mentioned as a part of the task force are still living and breathing without the goals of the SPI and have helped to bring other violence prevention work to the city of Atlanta or encourage more collaborations with existing partners thanks to gaps identified by the SPI. 2 specific examples include the very first Cure Violence site in Georgia, right in one of our target neighborhoods, and Georgia's very first Trauma Recovery Center, a mental health service model focused on serving primary and derivative victims of violence. We created a soft touch for gunshot wound patients where there had previously been none. We helped start important conversations about the need for this work and bringing local and state leadership to the table. We held a learning series where healthcare, law enforcement, and community partners were invited to attend to increase in-reach and communication across agencies. Topics included gangs in Atlanta and Cure Violence as a global approach to treating violence as a public health issue. The SPI contributed to the literature and is sought out by other sites looking to learn from our work. Our officers are still working in the communities. While the nurturing of relationships with residents may have been difficult and daunting at first, It has since become natural and positive. A resident shares that Officer Blackman is a familiar face. People recognize him in the community. They ask for him. They look forward to his being on the property. We know we can count on him. Pivot is also a known name in the community and is encouraging partnership. Hospital-based programs across the country were so excited to see us operating despite their apprehension to the law enforcement component because of the scarcity of these kinds of programs in the Southeast. The Atlanta SPI operates in an important space and is timely. A few insights. When you are doing something new, be flexible. Resist attachment to the product of your work looking a particular way because you limit your opportunity for evolution, growth, and innovation. Be creative and encourage creativity within and outside your team. Governance and decision-making processes should be clearly outlined in the beginning. This is especially the case for cross-agency work. Ownership and responsibility should be clearly stated. I recommend a project charter being developed in advance. If you have a research partner or not, they are extremely important to understanding how your work is going and what it means to be on track, as well as identifying new opportunities for innovation. A word on sustainability, think about this as you go. Identify areas that are currently dependent on a person and try to automate or integrate as much as possible. Nurturing relationships are key. You'll be together for a while. For example, I was based in the hospital, but the officers had my personal cell and knew they could always contact me to catch up, to troubleshoot, or facilitate their connection with a partner. Dr. Hawk and I collaborate and connect often. Remember to celebrate your wins as you go. You may experience challenges or delays, but learning is a success too. Thanks.
Thank you, Shyla and Jasmine. I definitely appreciate that. At the end of each of the presentations, we are going to take questions. Shyla and Jasmine, how did you all do the surveys that you had mentioned?
We did quite a few different surveys. We did internal and external surveys. Internally, we did a lot of collaboration measurement using the Wilder Collaborative survey. And we did that every 6 months to test how we were communicating, how we were building trust. And we talked about that in terms of people's anonymous feedback to the task force, but then also trends over time in development. We did surveys, windshield surveys, and community surveys, which I think is what this question's pertaining to. I just wanted to mention that surveys should be done on all different levels, but the community ones were done pre-COVID, and they, as anybody has ever worked on collecting residents' feedback, were quite the challenge. We basically threw every approach at it. We did an online version. We did with QR codes and links. We did a paper version. We had cue cards to read the survey to community members if they were unable to, understanding that there are educational challenges in these neighborhoods and some reading deficiencies. So some of our volunteers and researchers would read them to residents. Some of them would want to fill them out and turn them in later. We did them at bus stops. We did them on approaches in the community. We did them at community meetings and forums. We basically spent 3 months collecting resident surveys across the multiple communities in every possible way we could. And sometimes there was a lot of qualitative that went with it. There's hesitancy to give certain types of feedback, and particularly what we were in terms of personal exposure to gun violence and challenges with police trust in the police legitimacy. Those are all sensitive topics. So we were in turn sensitive in the methodology, and we were, while we looked at those depending on how it was given, how the data was delivered, in some it was very informative to our task force on what the community voices, and particularly I would say the hospital benefited a lot from what the community numbers were, the percentages of people that were exposed to gun violence and their perceptions of police when we were having conversations of incorporating the police into a hospital violence intervention program. And because the police are often in these communities, whereas practitioners, clinical workers and doctors had not been. Jasmine, do you want to add to that?
No, I think that was perfect.
So we did receive another question, which was, can you talk a bit about the process of gaining law enforcement cooperation and what changed once the police were on board?
So I have, Shyla, of course, jump in here. So I think that one recurring conversation best characterizes like the struggles in the beginning. So one of the prongs involved data collection and sharing, which is an expansion or adaptation of the Cardiff model, which I don't talk about very specifically here. But basically, we uncovered that over half of violent crime goes unreported to law enforcement. And as a part of our initial spiel to law enforcement leadership to talk about this program, we shared that information. And what sticks is that gun crime or gun injuries are not being reported by clinicians to police. And the law enforcement partners immediately wanted to address that issue. But we definitely continue to talk about how this was a collaborative approach, that there are some challenges with that across organizations and how our program hopes to address some of those things in a different way. What else can I characterize there? It took a little bit of selling on that point, I believe, and lots of continued engagement with APD as they were experiencing quite a bit of turnover within their leadership roles. Maybe Shiloh, you want to chime in on that a little bit?
I would just balance it to say that I recall the hospital being faced with a lot of the same challenges. I find it remarkable how similar police departments and hospitals are in terms of structure and red tape, turnover and buy-in, that really the only difference is language. And once you come to a common language, a common understanding, you can start to build that collaboration in a meaningful and actionable way. And it took some time. We actually spent longer in a planning period than we had originally intended in order to make sure that we were addressing some of those issues. And we definitely had both agencies experience some concerns, and it just took coming back to the table over and over and refocusing on the core principles, the core goals and values, and making sure that we were all had the right motivations and that we were using the same narrative. So I think that was key for us.
Thank you for that. And then another question is, can you please discuss the HIPAA issues? What type of information is shared with partners that are non-medical?
So the particular HIPAA issue we were facing with, I can talk a little bit more about Cardiff here. So the premise of the Cardiff model, which was our data sharing prong, was that violent injury data is collected in the emergency department, it's de-identified, and then combined with law enforcement data. And a coalition that has formed, which, in the state of Georgia for us is now public health, healthcare, and law enforcement, then shares that information with the community in which there are areas of increased violence or hotspots, and helps support the community in doing something to address, these additional cases of violent injury and crime that have been identified. So we had initial funding to do that, and the data sharing was covered in the related agreements associated with that funding source. But once we wanted to move to expand to include APD in that process, our previous police partner being DeKalb County, once we wanted to include APD, we wanted official ruling about the HIPAA level compliance of this data sharing. And that resulted in some very intense delays on behalf of the Office for Civil Rights and Health and Human Services to give us that recommendation of sharing the data first through a neutral third party of a public health agency before the data were then shared with the community or with the law enforcement partner. Now that we've gotten that go ahead, we're able to work on re-engaging APD and other police partners in the city, in the metro area actually, to be a part of that partnership, to share their data with us, and then to receive the combined data in some facet and work with us and working with the community. But it took at least a year, if not a year and a half to two, before we finally got some firm ruling. And then it was a matter of engaging the public health partner and bringing them on board, which took some time.
And I'll add just a couple of things about other data here. So we never sat down and did intensive case reviews of gunshot wound victims that came through the hospital. There was a patient level, there was a community level. We were aware when events were happening and who they were affecting, but the focus were for the different sectors. And in addition to that, we had every acronym that you can think of: MOU, data sharing agreement, National Institute of Health certificate, institutional review board. Grady has their own. We had all the different things to express. And even still, we've got a couple of papers that are under review at some journals, and depending on whether it's criminal justice or the public health or medical, we always get comments and questions about the HIPAA concerns. It varies by location, and we definitely had to make some concessions in order to meet the different legalities of that. And at different times it slowed us down a little. Sometimes we were able to come up with new ways, innovative ways to get around those that were not harmful. But in the end, we weren't focusing on anything but providing services. We were trying to help people. So we limited the PII that was shared and focused on the incidences and the services that were needed and how to move forward and address things in a public health way, rather than trying to sanction or solve cases. And that was a little bit of a sticking point with the police, because the officers that were in the communities did struggle to not be pulled into investigations, to not have them seen as someone that had to, that people in the community had to tell what happened to the shooting as part of the investigation, or for them to answer to how that investigation was going. These are all completely organic conversations, but there's something that if you can try to get a script or some sort of response to up front will really help when it comes to these sort of specific HIPAA questions in collaboration with non-law enforcement agencies.
Thank you both. If you have any further questions, we'll try to circle back to all the sites at the end if there's a little bit of time. So next up, I believe, is Commerce City.
Great, thank you. My name is Kim Messina. I'm the Victim Services Manager for Brighton and Commerce City, as well as the Project Director on this project. Today we have with us Deputy Chief Greg Sadar of the Commerce City Police Department and Dr. Lisa Ingerfield, who is our project researcher. If I could just, again, put in a plug for a researcher on a project, what a tremendous difference and a great partnership we had. And she'll talk a little bit more about that in a minute. So looking at our SPI project, if you look at the communities of Brighton and Commerce City Police Department, we have approximately 196 sworn officers between the two agencies. Commerce City is a little bit larger, with around 120. Our population is just a little over 100,000, and our communities are adjacent to each other. One really unique piece that we have in our community is that we also shared other shared units, shared ideas, such as our victim services, our SWAT, and then we also have a combined North Metro Drug Task Force, which includes multiple jurisdictions around us. Both cities had conducted an internal audit on sexual assault response, and those findings really kind of laid the foundation for we were having difficult times with these types of cases. Both cities had also implemented the You Have Options program, which is a sexual assault platform that allows for victims to report in a way that worked best for them to law enforcement, as well as the program is developed on 20 elements, which allows the victims as much control over the investigation as legally permissible. So when we looked at developing the task force, there were lots of we know that sexual assault is an ongoing issue requiring specialized attention. We know that less than 20% of victims report sexual assault to law enforcement. So in additional efforts of implementing the You Have Options program, which we did see an increase in reporting, we wanted to do more. Neither city actually had the resources available to them to put a specialized unit together. So again, we had multiple examples of jurisdictions and task force for other crimes such as drugs, auto theft, and so we kind of gathered our idea from there. Both cities made the decision with a great deal of support from the command staff, the chiefs, the district attorney, as well as our city councils, which I think is really key in these projects, is that when you have the buy-in and the support of council and those community partners that you're going to be working with, along with your command structure, really makes a huge difference in opening communication, opening doors, and being able to address issues. So we applied for the SPI funding and we received it.
So the problems that the Sex Assault Task Force was focused on changing was overall increasing the level of quality and thoroughness in our sex assault investigations. We every once in a while you get an easy case that's very straightforward and you put a lot of time and effort into it to make it a successful case. And sometimes you run into those cases that you know are going to be a difficult case. And we found through some study back in 2015 and 16 that there was some clear shortages in those more difficult cases. A lot of effort wasn't put into them the way it should have. So we really wanted to focus on quality. Teaching our cops to embrace trauma-informed interviewing of our victims and witnesses was a critical aspect. We do a great job of teaching our cops how to interrogate suspects, but we don't do a very good job of teaching them how to interview victims and the critical differences there. One of the most successful things we were able to do is fill in that specialization gap. Prior to the sex assault task force, we had general assignment detectives in both agencies working sex assaults. And when you're working an auto theft in the morning and a burglary right before lunch, and then you come back after lunch and work on a sex assault for a little while, it's difficult to get those genres lined up. But when we specialized our detectives through a task force environment, they not only did they develop the expertise more quickly, they found that they were able to move through the cases much more efficiently because they weren't distracted with things that were kind of interrupting them. We were really proud to work with our victim advocates and our communities to increase reporting. Each year we've seen significant increases in reporting. We've offered a whole different variety, as Kim mentioned, through the YHOP process, several different methods for victims to come forward. I don't know that we've proved that the rate of increase has improved overall beyond that of the growing population, but we have provided our victims much more comfortable environments to report their sex assaults. Increasing our utilization of the victim advocates was critical. In fact, we embedded 1.5 full-time victim advocates into the task force, smooth out the working process. So a detective wasn't working with a different advocate each case. And it was really nice. Probably one of the biggest wins was we were able to congeal what was otherwise kind of a disparate, siloed approach to all the different services available to our sex assault victims. We were able to take the law enforcement, the community services, the social services, and bring them together at one table at a minimum once a week for meetings. And each of those problems we were able to identify, find solid workarounds, and ultimately to more or less resolve.
So the structure of the sex assault task force has 4 detectives and 1 sergeant. It also has, as DC Sadar mentioned, 1.5 full-time advocates embedded within the task force. Originally, when we looked at the structure of the task force, we were going to only have 1 advocate in there. However, we quickly realized that being victim-centered required some additional work. And our advocates work hand in hand with the detectives. And so we had to increase that staffing there. VAs also are called on every single case at the patrol level to ensure that we begin those relationships. The structure also includes weekly meetings with our community partners, which I can't stress how important those are. Talking about working across different agencies, trying to find a common ground, finding common language. I mean, there's definitely hiccups in that process. However, the benefits far outweigh what those are. And so just greatly successful in that. We also agreed that both agencies would continue the You Have Options program. And the structure was not about case closure. It wasn't about getting through cases. It was all about the quality of the investigation from the time that it came in all the way through justice, whatever that looked like. Again, we have those community partnership meetings, and then we also have sex offender management inside of the task force. And DC Sadar will talk about that a little bit more. So when we look at some of the successes that we've had at the task force, the task force is co-located right between both cities. So they're in their own building, which has really proven to be successful because it increases communication. There's real-time communication. It also allows for this critical training of investigations, victim services, and trauma. So all of those different pieces and components are coming together to increase the success of the task force. We quickly learned that callouts in each city were different. So blending those cultures was turned out to be really successful. We had, again, the real-time communication. the success of having an advocate internally in the unit really streamlined processes for victims and also for detectives. It just freed up additional time that advocates could spend with victims while still getting really important information. We also were able to limit the gaps in conversations that sometimes when we're away from each other tend to happen. We did notice throughout COVID that communication was one of those issues for us, just because although we were doing Zoom, we still do weekly Zoom meetings, that personal interaction is really huge. So we have missed that. However, we still communicate really well. Our community collaborations, it only enhances the investigation as well as supporting the victim. So kind of having those wraparound services for victims to help them stay engaged. Some other successes is our strategic planning reviewed annually to not only to recognize the overall success, but including team members in that strategic planning and producing annual reports and updates to our city council, to our DA, to our command staff and chiefs. Again, it just really pushes out not only the success of the project, but also the buy-in from everybody else.
So like with any other work group, we ran across a number of challenges. Most of those were discovered early on the implementation process. Some of them linger with us today. But by and large, we were able to get past most of them. First was obviously the older legacy cases. Each agency had some cases they weren't super thrilled with, or that that were currently in progress when the task force kicked off. And what we had decided in the beginning was taking a backward look at some of the older cases simply wasn't going to be a viable option given the resources we had. So we took kind of a go forward approach. And, the in progress cases, those were, we just had to deal with those the best we could at the moment, not to race them, but to figure out how do we unbreak them if they were currently broken cases. Infrastructure, like with any co-locating of disparate pieces is a big issue. Like in many other states, Colorado has some agency-specific evidence rules, specifically around DNA evidence, which is a big deal in sex assault cases. IT infrastructure was absolutely the biggest problem we had initially, and it still plagues us a little bit to this day. We've never been able to really satisfy everybody's needs. The biggest issue with IT was, we have IT sections in both Brighton, Commerce City, and at the Adams County, the county level, because we used a county building. And while each of those unique agencies have security needs for their internal stakeholders, everything we ask them to do required them to relax a little bit of their control over some of their security features. And that was a challenge. Multiple one-on-one meetings didn't seem to really resolve a few of those issues. By and large, we were able to get operational, but it's still not great. Along that same theme was the blending of cultures between the two different agencies. Some agencies have the approach of, well, that's just not how we do it around here. And so what we did was we wrote an SOP, and ultimately that ended up being a top-down discussion. We just, Kim Messina, Lisa Ingerfield, one of the Brighton commanders, Matt Domenico, they built out a dynamite case rubric, and we ultimately just wrote out policies saying, this is how we're going to do this. These are these national best practices we are going to implement. And over time, everyone ended up jumping on board. We were absolutely plagued, like many law enforcement agencies, with massive turnover problems. That is continuing. But one of the things that I think testifies to the sustainability and success of the task force is, even though we've had kind of a high turnover rate, higher than we would like, everyone that has jumped on board has gotten involved in the philosophy of the task force. So that's been a big win. Another challenge was early on, before the sex assault task force had implemented itself, a decision was made to move our sex offender management into the task force. We pretty quickly found out that was a square peg in a round hole. Just because it has the word sex in it did not necessarily mean that those two theories aligned well. We went through at least 4 different iterations of how we ran that. And I think we've run into a fairly successful situation at the moment, but what it really ended up meaning was divorcing the process back to the two agencies. There was a number of issues around that we can talk about at some other time. And then environmental issues. Moving in, the very first year, it took us a while to secure a real estate contract. In 2019, we had 3 sergeants in 1 year running the unit, and that was a huge problem with us. Obviously, 2020 with COVID impacted us the same way it impacted everybody else. And again, to brag a little bit, I think the fact that we have continuing success in the task force, despite these really significant curveballs, speaks to the validity of the process we implemented.
So I'm going to talk a little bit about the evaluation plan and how we've been tracking success. So one of the fundamental philosophies we took into this was the action research methodology. So really situating and embedding goals and outcomes in the unit. So what is it that Brighton and Commerce City police departments and the detectives in the task force want to see? Having conversations with leadership about what does it mean to do quote unquote better sex assault investigations, because better is a bit ambiguous. So we really tried to nail that down. And then through those conversations and then through the research and best practices within law enforcement around sex assault investigations, we were able to develop this case quality rubric, which is how we have been grading all of the cases that have been coming out of the task force. And the analysis, the primary analysis that we're doing there to determine whether the task force has been successful is the interrupted time series analysis. So we're comparing before and after the intervention, essentially. I've also been conducting a number of qualitative interviews. First, I was speaking with detectives in the unit, the victim advocates, community partners about the process of implementation. So what did it feel like to be a part of this new unit? What bumps in the road have you noticed? What's worked well, as an opportunity for us to learn about how to do it differently or for another agency. And then I also spoke to detectives in the general investigations unit to find out whether lifting sex assaults out of their purview affected their caseloads. Like, did they feel it? We've actually had a complete turnover of detectives in both general investigations units since the start of this project. So I was able to conduct about 2 rounds of interviews there before the folks in the units didn't have any history of the task force. But on the whole, we found that it had made an impact. Kim's victim services unit does send satisfaction surveys to survivors. So we tweaked those a little bit to get at the task force efficacy. And so we've had a few responses to that. It's very hard to evaluate victims' experiences because often they just, once they're done, and they don't really want to go back through the experience in a survey. We're tracking cases both at the task force and at the DA's office to see what criminal justice outcomes are. And then I'm also documenting the process of implementing this task force so that we can use that as a roadmap for other agencies. So I'm going to focus here on the case review because this is the biggest piece of the evaluation project. So initially we had decided we were going to review 100% of the cases in the 3 years prior to the task force and 100% of cases in the 3 years post the task force. And then very quickly realized that that was just an enormous lift that was just insurmountable, particularly for Kim and the sergeant, who is the other reviewer. It was just too much because it's such an involved process. So that's definitely been a learning for us. So we dropped that down to 50% of pre-SATF cases and 50% post. As I mentioned, there's 3 reviewers and we're each reviewing 2/3 of the cases. Originally, we were all going to review all of the cases. And again, we made that tweak after we realized that there wasn't the time to do that. We're scoring cases based on patrol, the investigation, the victim services contribution, kind of a general case, like is everything in the case part. And then we have a weighted section where we pulled out particular things that were most important, like was a victim advocate called out, right? So we scored that a little higher because of its importance. Each item is scored on a 0 to 3 points. So 3 points, it was 100% done, 0, it wasn't done at all. On items where it wasn't applicable, like Was there a medical forensic exam, which would only be applicable within a particular time frame after the survivor reports the sex assault and particular types of sex assault? We would put a not applicable, so it wouldn't be included in the calculation. And then we had to decide on 80% agreement in scores. So where there was a discrepancy between the two reviewers that was greater than 20%, we then sat down and re-reviewed the case to come to an agreement where our scores came into alignment. And then each month we average the cases to get one data point per month. So essentially we'll have 36 data points pre-task force and 36 data points post-task force, and that'll be the comparison. So I just want to quickly go over some of our case review themes. So these were the themes that we saw in the cases before the task force was implemented. So a lot of lack of crime scene documentation and visitation, and that was particularly apparent in school settings. Cold cases, often it's not applicable, but there certainly were a number of times where a visit could have been helpful. We also saw lack of contact with the suspect, very little investigation into the suspect's background, patrol, a high number of patrol level case closures when they really shouldn't have been closed at that level and should have been forwarded to general investigations. And then when there was a lot of language issues in the reports pre-task force. So like articulating that the assault was something that it wasn't. So the language was it wasn't precise enough. A lack of non-consensual language. So they wouldn't, it would be the, alleged perpetrator had sex with versus sex assault or rape. And then we would often see these quotation marks around words like rape or vagina or period, which didn't make any sense. As an outsider, I originally thought that was like purposeful, I saw it so much that I thought that officers were told they had to do that, but it actually isn't a thing. So that was what we saw initially. And so then looking at the case review themes post task force, we're still reviewing 2020, so I don't have any data on that right now, but we continue to see this lack of suspect investigation or any kind of documentation of looking into the suspect's background to establish a pattern of behavior or priors or anything like that. When the reports are poorly written, we are seeing things like unclear details, very vague information, a ton of spelling and grammar mistakes. There's often kind of an undertone of disbelief, and then follow-up questions are infrequent. There's still a lot of unexplained gaps in time between supplements and then an overuse of running supplements. So the running supplement meaning that the detective isn't, or patrol officer isn't entering the supplement at the time that they do the work. They're after the fact going back retroactively and creating one supplement with all the dates in about what they did. A lot of limited documentation about victim communication. We had factual errors that seemed quite enormous in terms of it could affect the likelihood of prosecution. A lot of delay in reaching out to victims. And then we also saw a number of cases that just ended. So there was no documentation about how the case concluded. Did it go to the DA's office? Was it inactivated? Like it just stopped. So we definitely saw that. Which also sounds like a lot of case review themes compared to the 15 to 17, but it is better. We're just seeing some different things. I just wanted to include this. This is the average monthly case scores. So that single data point from 2015 all the way through to 2019. So the task force came in at the beginning of 2018, but you can see that there's an upward trajectory for both agencies. Brighton is the circles and Commerce City are the stars. And so we have continually increased in terms of the case review scores. So the quality of investigations across all areas has been going up since the implementation of the task force. It was already going up before because there was some training done, but we haven't seen that flatten out. We haven't seen that decline. So that's really exciting. And so I'll leave it there. And we have one more slide about some lessons that we have learned.
We did really learn a lot of things as we've kind of taken this rearward look at the 3 years in the task force. Merging the work styles has certainly been rewarding, not because it brings the workers closer together, but it's really elevated both work styles. The IT issues, like we mentioned earlier, really have continued to be a problem. As I've talked to other commanders and other task forces, they all run into the same problem, and it's probably something that our future partners would run into as well. Staff turnover has made, we were kind of hoping that we could train up a core group of people and that they would serve to train others over time. Turnover has been high enough that we've realized we just need to have a constant ongoing training program. That's a little disappointing and a little expensive, but it does at least keep you on the cutting edge of training. A multidisciplinary approach to these cases has been absolutely critical. Again, the biggest win that we've had is being able to bring social services to the table, bring therapists to the table, other community partners, having a prosecutor that sits at the table with us when we roundtable cases has really done a remarkable job of finding good points and bad points in cases before we even have to present the case to the DA's office. And it's really made for more well-rounded cases. And one of the things we've seen as we continue to roundtable cases, some problems continue to be noticed, but a lot of the earlier problems that we used to really kind of struggle with have just been kind of trained out of the staff, which is a really exciting thing to see. Supervision is an absolutely critical issue, and it can't just be at the first line supervisor level. There has to be a command view into these things. The commander doesn't have to run the cases, but the commander really does need to stay hands-on with the unit. Otherwise, you will see some drift. First line supervisors are absolutely the single most critical point in the task force, but supervision we found is when we take our eye off the ball, it will fall a little bit. A more structured onboarding would probably be necessary. We would like to all have highly skilled, highly experienced detectives immediately filling these roles, but we have to recognize that there's going to be a little bit of a learning curve for most of the staff that ends up in a unit like this. And you really have to select the right people. Not everybody makes a great sex assault investigator. And we have to be realistic about nurturing the newer staff members, or the ones that don't have a particular knack for it. And then if they can't wrap their head around it, we need to find a graceful way to help them move on to something else rather than make it look like a negative process. That's all I have there.
Thank you all. We definitely appreciate those perspectives. I think we have time for maybe one or two questions. Does the review inform the development of new training materials?
Yeah, the intention is to provide that feedback to detectives and patrol and the victim advocates on, how the cases have been scoring and patterns that we've been seeing as a tool for professional development, and then also to identify areas of need in training. So do we need to do more around trauma-informed interviewing? Do we need to do more around the ins and outs of investigating sex assaults, or strategies for navigating suspect background, beyond just the regular background check? So there is intention, yes, to utilize that. I don't know if DC Sadar, Kim, you have anything you want to add there?
I would say that the case reviews absolutely pointed out the importance of training the detectives on trauma-informed interviews. And as we continue to review those, it's not a commonly used practice. It's gaining popularity, and it should, but that emphasis on training would not have happened had the scoring process not revealed the importance of that.
I also think it's very interesting too, when we looked at our pre-themes of the task force and then post-themes, our rubric was designed off of best practice from Ending Violence Against Women International, PERF, IACP, several publications, and experience through the You Have Options program, nationally recognized. And so our focus was really on identifying suspect information, whereas pre-task force, it wasn't quite on there. So when you look at some of the post-task force themes, or during task force, they're looking at different things that maybe they hadn't looked at and scored lower before.
Why don't we move along to St. Louis? Next slide, please. And Emily and Dennis.
All right, hi, great. My name is Emily Blackburn. I'm with the St. Louis Metropolitan Police Department, and we're going to talk today a little bit about the mobile surveillance units that we put out. And we did a randomized control trial here in St. Louis, and our research partners with me today, Dr. Dennis Maris out of SIUE. The aim or the purpose of this particular SPI was to bring flexible technology that to underserved communities, because here in St. Louis we have a really vast network of both LPRs and cameras. We've got well over 250 of both, but what we found was we couldn't get into a lot of smaller areas. So a lot of you with tech build outs I've seen in the new sites, you're going to find issues with like fiber networks and Wi-Fi and things as you build out. So what we found was we could put these sky cops into those locations. So that was the main point of getting this flexible technology into these underserved locations, given that we're a city that has a very high rank of violent crime. So something we could go into these smaller areas and deal with this violent crime. And as I said before, we use many of these technologies already. We had several mobile surveillance trailers or sky cops already deployed, but they're deployed a little bit randomly, depending on who's got the ear of whoever's driving the sky cops around. So we wanted to set some rules and set some parameters and make sure that we were using the sky cop in the best way we could, and make sure there's a really data-driven approach. So the easiest way to do that was to start a new grant cycle and really take that in a different direction.
Right, so the Sky Cops were really particularly chosen to address pockets of street crime, as Emily was saying, because they're one of the few mobile platforms that you can move around to other places as the need emerges. And so the Sky Cop platform really allows you to integrate multiple technologies in one, so the units can contain both CCTV, gunshot detection technology, as well as LPR capabilities. And our belief obviously is based on deterrence theory and the idea that if you that you can deter crime from happening in specific locations by putting strategic resources there. It also was the belief that we could increase the intelligence capacity of the St. Louis Police Department, because the technology on board would allow you to capture video, would allow you to capture license plates, so that hopefully would then lead to a higher success rate in prosecution, for instance. So the key collaborators in this project are the Real-Time Crime Center, who is mostly responsible for deploying the units and monitoring the units, the Crime Analysis Unit that Emily works for, and myself as research partners. And so we were allowed to purchase 3 fully functioning mobile surveillance units with all the accoutrements on there. And we also purchased 1 unit without any technology on it. It just has the lights, and the lights do blinky stuff, but they don't do anything else. So this was supposed to be our placebo, right? Because our thought was, if we're going to evaluate this, we also want to see if it's really the technology that's making a difference in these locations, or if it's just simply the presence of something out there that looks intimidating, because these units can be perceived as intimidating, as some of the surveys told us. So all the grant units were then deployed in the high crime locations. So the approach to deployment was, initially we had thought to use software to lead us to the deployment, and the software was then taken over by a different company and was changed around, and it was totally not suitable for what we wanted to do with the project, because it wouldn't allow us to pull data back out. That was one of the main problems. So we then came up with a creative solution of doing a relatively straightforward predictive hotspot analysis that was produced by the CAU unit. So Emily's unit produces this and then sends it to me, and then I randomize the locations. So I look at the top locations in each district, and I assign randomly, I have a pre-made sheet for this, whether a location will be a treatment site for the mobile surveillance unit, or whether it will be a control location that doesn't get any treatment at all. And if we can compare those over time, we can get a better sense of what's working, what's not. So then our Real-Time Crime Center friends help us out, and they move the Sky Cops to the right locations. They will monitor everything, and they pull data from the acoustic location, from the acoustic system for us if we need to. And we deploy the units consistently for 3 weeks at a time. The idea is that we need a little bit of time for these units to start working and to collect data for us, for them to be as functional as possible. So the idea, of course, is very sustainable as we've done it post-grant. So once the grant cycle is over, these units can keep being deployed in the field just as we're doing now, with relatively, little complexity involved. So that really is sort of the idea of this sustainability.
This is a bit of a fun slide. So we'll talk a little bit about our early results from the data, but we're also getting this additional bonus of this. Not only does it have some crime effects and deterrent effects, but it adds to our intelligence capacity too. So having these units into the real-time crimes that are federated in and having the license plate, the camera, and the acoustic technology we found is very helpful. So it's just a slide of, for whatever reason, one of the screens in real time was up on the SkyCop in late November, and it sees this, vehicle kind of just going down the street with no lights on. And we've got some really good folks in real-time crime centers. So they just kind of noticed it and tracked it. Like I said, we've got a couple hundred cameras and a couple hundred LPRs. So we just kind of tracked it through different sites. And it kind of went off site for a minute. And when it came back on, its window was missing. And clearly there's an airbag hanging out of the window, of that front passenger side window, which put it right in a place with a shooting we had. So we were able to engage in a pursuit with a lot of intelligence and get an arrest very quickly. So even though this is a very academic, randomized controlled trial situation, we're still getting this day-to-day intelligence capacity out of these SkyCops. So that's just kind of a fun added bonus.
Yes, and going back to the academic side of things. So we were really still not that far along in our data collection process. But what we were able to do is have a full cycle of deployments to all the districts in St. Louis. And so from that, we did an initial analysis, and luckily what we found was very good news. So we found, for instance, that in the locations where the SkyCops were placed, compared to the control sites and compared to prior rates of crime, we found roughly a 23% reduction in total crime in those locations. When we looked at violent crime, and with violent crime, that number is a lot more variable, because violent crime is obviously still very, very rare, even at small locations. We found, though, that for violent crime, that decline may be even higher, and we found about 40% decline. And we hope, of course, that continues on as the project moves on. A couple of other interesting initial findings were that the deterrent effect of the units sort of persisted even after the SkyCops were actually removed. So there was some persistence in that deterrent effect. Hopefully with more data, we can get a better range on how long that effect persists. But for now, we seem to find that in the 3 weeks following the deployment, there is still some residual effect. Interesting too is that the deterrent effect, at least from the initial data, does not appear to be as large as we hoped. We mostly found deterrent impacts in about 500 foot from the units. So maybe with more data, we'll find a larger radius, or maybe we'll stick with that 500. It's hard to tell for now, but that's kind of surprising. We were really hoping that deterrent effect would stretch out a little bit further. Now, good news though too from what we found from surveys, because we did both pre-surveys with our police department as well as doing surveys to the public. What we did with the SkyCops is we posted QR codes on them. So members of the public who see those QR codes can then fill in a survey. It first provides them some information about what the units do, and then ask them if they want to do a survey. And from those survey results, we mostly got very good feedback. People seem to like the units. They like the idea of it being there and doing some degree of surveillance for their neighborhood. We also found that the officers in the police department are very supportive of technology, both technology that was already in place, so CCTV, LPRs. And even though the knowledge of the SkyCops was not very widespread in the department yet at the time we did the survey, we did find that the people who knew them really liked them. So once the project is complete, we'll do another survey among the SLMPD officers and see exactly how much their view of SkyCops has changed over the years. And we hope, of course, that is a positive change.
Okay. So the other lessons learned and insights with this is early results are not great on the gunshot detection portion of the SkyCop setup. So that's about a $30,000 extra cost. So it was very important that we wanted to look at that. In hindsight, with the scope of the SkyCop effectiveness only being about 500 feet, it's probably not surprising that nobody's firing a weapon within that 500 feet under a blinking red and blue light. But we had hoped, we'd have something a little cooler, but it isn't. But as far as SPI is concerned, that's a really good lesson learned, because now if we recommend SkyCops to fellow agencies, that's something we can say, save yourself 30 grand, buy 2 instead of 1, that kind of thing. So that's a really good lesson, even if it wasn't what we wanted to find out. We also looked at placing 2 units closer together to see if, 2 plus 2 might equal 15, a bigger bang for our buck, but it didn't prove to be the case. So now for the rest of the deployment cycle, we're going to not do that anymore and move those about. So just showing some flexibility in our research and how we're learning it and evolving it a little bit. And with our QR codes, a few of the survey respondents were mothers of young children who thought that the red and blue lights shining into their babies' windows during naps was really not great, and asked us to please stop. And when that came into Dr. Maris, he called us straight away, and we changed our policy immediately. And now not only on the SPI SkyCops, but on all the SkyCops, if they're in dense residential areas, we do make sure to turn those lights off. That's just a new department policy that we were able to adopt really quickly after only, I think, two mothers or 2 parents contacted us. But we wanted to quickly take that into effect because we want to keep the public on our side. Surveillance issues in the city of St. Louis, as they are in a lot of places, are very politically sensitive. So we wanted to be sensitive to that. And then also what I was able to do very quickly after this review that Dr. Maris did was talk about it at ComStat and kind of make some slide digs about how we place the units, and started to get the captains on board with maybe using a more data-driven approach to deploying our fleet and how we would space them and things like that. So those are really early lessons that we've been able to make practical on the ground changes to how we police here in St. Louis that I think was really positive.
So I think the advice too, and this goes, especially for new sites just starting out this year, is really think about your evaluation plan, particularly in relation to how you develop that action plan. Where possible, and that is not possible obviously for all sites and for all projects you guys are doing, but if you can, use control sites. There's an important reason why you'd want to do that, particularly with what's been going on over the last year. So in many locations, we've seen violent crime go up a lot. If you did your project during this year and you had no control sites to compare it to, it would probably show that your violent crime increased. And that is not a good thing, of course. And the control sites really help with that. We added the placebo in on top of that because we were able to luckily do that. And we're hoping to see some results on that. I think it's also great, and St. Louis was really great in working with me on this project, and throughout the project continue to work with me on this. We really have worked well together in figuring out what specific data needs each and every one of us needs. And we have set up a schedule on how to do this essentially, and it is really running smoothly now. And I think thinking about those needs early on and coordinating those needs early on is quite important. That being said, as a research partner myself, I really have to think hard too about the limitations of what you can do in an agency, right? There are certain agency needs or political needs. So we have to always, as research partners, not be just concerned about the academic research we can produce off this, but also, what works in the location and how can you make that happen in a way that is, satisfactory to the department, but also maintain sort of that research rigor. And that's it for me.
The only thing I had left that I thought about is, as I heard other presenters do their presentations, and we're talking about flexibility in data, is one of the things we came across when we started purchasing this fleet of these mobile surveillance trailers or these SkyCops is, as a police department, we don't have any rules around asset tracking. So we don't have any data source to say where something was. And so, we worked with CAD, the CAD system, when we made up these, we assigned like police numbers, designated numbers to the Sky Cops, and we had them call out through CAD, and we really went through a lot to try to figure this out, and it worked okay. But what I had originally wanted was a GPS lock on the trailers, because I felt like removing humans from the plan was the best plan. But our management didn't really want to go with that extra cost at first. And then after a few months of that being a total disaster and not knowing where some Sky Cops were when we had to pull them in quickly due to civil unrest, we went back to Emily's original plan to put GPS tracking on those Sky Cops, which is what the Real-Time Crime Center had wanted too. So now we're back at that. And now Dr. Maris and myself and everybody has a much better sense of where all the Sky Cops are at all times. But it's just, how do we work together for different needs, and just being creative and flexible and thinking about how we handle things. But that's all I had. So questions?
Great. So we have quite a few. So if we could just try to get through them as quickly as we can. First of them, there's a couple sets that look like they might be for Dennis. Were any of these placed in locations that there are permanent IP surveillance cameras to see if there's a difference between visible cameras and non-visible cameras throughout?
In all likelihood not. It's hard to tell exactly where all these assets might be, particularly since I do the selection, and so I don't know where all the cameras are, to be frank. But our main research plan was to put these units in residential areas, so those are typically very, very small streets that don't have those assets in place. So in St. Louis, many of the cameras and the LPRs are really on the main thoroughfares and in downtown area. And those areas were specifically excluded from the research project because of that reason. Now, it is an interesting question, and it is something I'm going to address. St. Louis has a couple of mobile surveillance units that were purchased through the Police Foundation in St. Louis, and they are predominantly deployed in downtown St. Louis. And so in that case, you do have probably both fixed LPRs and CCTV cameras on site, as well as those units. And that would allow you indeed to do that comparison. And that's something I'm going to be working on mostly for my own interest to see what's happening there. But obviously with the project being focused on residential areas, that was not particularly an immediate concern for us for this.
And I would say too, with St. Louis, as far as the cameras that we own, they're almost all high visibility cameras. So we do not hide the fact that our cameras are out. We'll deter crime all day long as opposed to videotape it. So all of our cameras are high vis and all have flashing lights that are in those main areas.
Just very briefly, have you noticed any effects between the placebos and the actual units?
No, because the placebo unit wasn't ready until just recently, and it only started going out for the last 3 deployments. So we haven't been able to gauge how effective that is. But I am just dying to figure out how effective this stuff is. So yeah. I'm going to be keeping a very close eye on that.
And then a couple of questions, I guess maybe for you, Emily. Do you know how much they cost per unit, and what are some of the annual or monthly operational costs for them? And then are there any insights that you have on either how to orient some of the facing directions of the cameras or patrol nearby as a result of these units? And then for the other question, Bridget, can you go back like 5 or 6 slides to their title slide to get a picture of the actual unit?
Okay. To the question, I want to say that the units were about 80,000. So if you take the acoustics off, you can get around 50, I believe. The cameras, they are PTZ, if I recall correctly. So we just kind of, once our detective drives them into the spot, and Dennis is really good about giving them very, very clear directions, replete with like pictures of Google Maps of exactly where we want them placed per their request. And so then Real-Time Crime Center goes in and they just kind of move those cameras around to try to get the best picture they can. So there's a little finagling there, but those guys do it all the time, so they kind of get us the best view they can.
Yeah, and to add to that, Emily, I think at this point you guys have an SOP developed for setting those units up. I think there's a whole list of checklist that all the, particularly with the units, some of the original Sky Cops now going out to the districts as well. that there's a checklist that officers have to go through to set up the cameras, because if you don't do it right, you don't get any proper image from them. Same thing with the LPRs.
Good afternoon. My name's Henry Remolina, captain in the Providence Police Department. Real quickly, we're the capital city in the state, urban environment, obviously, and we were having trouble with a small percentage of individuals really taking up and using up our resources. This was the reason for the resources. Their root cause were alcohol, drug abuse, and mental illness. It was not only police being affected, but also fire, our rescue runs, and our ERs are being tied up. So the small percentage were really tying us up. And for the police department, we had two approaches: either arrest them or we would transport them ourselves or get fired. Obviously, with HIPAA, that was the end of the road for us. We never knew what happened to them. Once we put them in there, they'll come right back out, and we were on this merry-go-round. We couldn't get off. Luckily, we've had an ongoing relationship with working relationship with a social service agency, also the Providence Center, a mental health facility, and Roger Williams University. So when this grant came around, it was a natural merger for us. I'll turn it over to Stephanie.
So as Captain Remolino was saying, part of the impetus for this project was the fact that the city of Providence not only has the largest volume of violent crime in the state, but has the greatest number of overdoses and substance abuse treatment admissions. So we had 4 overall goals of this program. The first was to actually attempt to reduce the number of arrests and the use of the ambulance service of this target population. We had estimates that an ER run by the ambulance was a minimum of $2,000. So there could be a significant cost savings to reducing these, as well as, of course, relieving the police officers of some of these calls as well. We were hopeful that we would be able to show a reduction in arrests for these high-risk offenders that exhibited the behavioral health concerns and issues. We were trying to increase access to the low and at-risk offenders with some of our behavioral health their behavioral health needs. I'm sure we adapted some too as we went along, and increase law enforcement's capacity to respond to these individuals. There were 3 key partners in this project. Obviously, Providence Police was the lead funding agency, and myself and Sean Verano from Roger Williams University served as the research partners, and we helped design the treatment plan and how this was going to be implemented, along with a lot of the forms that we were going to need. We did a lot of documentation throughout this process by the officers who responded to the calls in conjunction with the clinicians from the Providence Center. And this project really built on a pre-existing relationship between the Providence Police Department and the Providence Center. So we created these behavioral health response teams specifically for this grant. And as the captain mentioned earlier, the idea was to de-emphasize arresting these members of the community in favor of some behavioral health support.
Here you can see how we were selecting our clients. The police department, the beat officers, they know who's training the resources. They know who they're out there every day, either dropping them at the ER or calling rescue. But we also wanted to be careful, and we removed individuals who are prone to violence just to avoid any issues. But at all times, we would approach someone, we would do an assessment, and anyone who didn't qualify, we would refer them. We didn't just leave them out there on the street. Now turn it over to Jackie.
Thanks, Captain. So as the captain suggested, we had targeted individuals that were high utilizers of first response services, be it police or fire EMS. And really, we wanted to target the highest utilizers there, but make sure that we are screening out for folks who were criminals and were having a lot of contacts with police as a result of criminal behavior. So we cross-referenced the data with fire and kind of deduced that if they're having both high utilization of police, but also fire and EMS, that we could suspect that they likely had some sort of behavioral health issue. Now, of course, it still could have been a medical issue. And so that's where our clinicians would get involved. We would do a brief screening to be sure that it was behavioral health in nature, whether it was mental health or substance use. If they were ineligible for the program but needed some other resource, we would redirect them to more appropriate avenues. If they were eligible for the program, we would most likely refer them to the Providence Center's network. The Providence Center is the state's largest community mental health agency. We run a variety of programs and services, but we're not the only mental health agency. And so there were times when we would intervene and we would find that folks had a preference for a different agency or were already connected somewhere else. And so we would refer them to those places while still trying to assist and facilitate to ensure that they got their needs met. For folks who never followed through with those resource referrals, we continue to do aggressive street outreach by the behavioral health response team, just to be sure that we weren't missing the opportunity of willingness. We wanted to stay with them through their motivational cycle and monitor for when the moment would strike and they would be maybe more willing. And what we found is that it sometimes it cycled a few times and we had to kind of circle back and even though folks maybe weren't willing today, they might be willing tomorrow and then not willing again the next day. And so we were just very persistent and did a lot of street work. For people who did agree to engage with our system or another treatment provider, again, we stayed connected with them while also ensuring that they were receiving more intensive services through those other resource networks. They would have individual service plans, treatment plans with client input developed, and we would ensure that we were informed on what those goals were so that we could reinforce what was happening in more formal clinic settings out on the street when maybe some of those resources were not as readily available to them.
One of the things we had to work out was the cultural differences. We created a script. So the officers, like I said, we know who are our target audience. We would go up to them with our members from the mental health community, from the Providence Center. We would introduce them and then we would step back. And when we were stepping back, that was an adaptation to HIPAA and also to give them privacy, but we would monitor to make sure our partners were safe and that the situation did not get out of control. Jackie, you want to add to that?
Yeah, so I think what we found is that a lot of our folks we knew that they were transient, but they were even more difficult to find than we realized. A lot of them, although they kind of had areas of the city where they were known to frequent, they move around and different times of the day, they would be in different areas and we would really have to go behind buildings and sometimes they were in apartments that didn't belong to them and we would have to just get creative as to where to find them. And so it was challenging because we would, maybe agree to meet them on one street corner one day and then they were, totally different place when we went to go outreach them. So we found that we couldn't really have a really set schedule of who we were going to see and what we were going to accomplish. It had to be more fluid than that.
I would just add that you have to remember, these are, for lack of a better term, the worst of the worst. These are the most difficult clients. So the fact that we were able to engage and able to build a relationship with them where so many others had failed, I think that speaks for itself.
Yep. And despite those challenges, as you can see, there were approximately 40 clients that were engaged nearly 700 times, which is pretty impressive. That's not to say that every one of those folks agreed to participate in treatment. There were plenty of people that would adamantly refuse. But when we showed up day after day, they continued to talk to us and accepted resources from us. So although they, maybe never signed participant waivers or consents to treat because it felt more formal to them and in a way that they couldn't trust us or police officers, they were still willing to receive services in a very informal way. Although the Providence Police Department and the Providence Center had a pre-existing relationship for nearly a decade, our prior work focused more on crisis evaluations and 911 emergency type interventions. And as soon as we got started on this SPI project, what we realized that the quality of these interventions was going to be fundamentally different. Crisis work is really a brief intervention. It relies on rapid rapport. Clients' voluntary participation is really not necessary, although it's helpful. But with this work, they had to be voluntary to participate in conversations and to get anything meaningful out of this work. And it required that we develop long-term relationships with our clients, and not only us as clinicians, where we're more used to that, but police officers who are not used to developing those types of long-term relationships. What we found is that many of the police officers did, in fact, know these folks, and they have had informal long-term relationships, but not in a therapeutic context, not necessarily what clients would feel as a helping relationship. And so there were a lot of trust issues that came up sort of immediately. And that, I would say, was kind of two-sided. There were clients that had trust issues with police officers, feeling like they would be arrested or they were going to be policed into compliance. And there were trust issues with clinicians, feeling that they had engaged with providers in other capacities before and didn't get their needs met for whatever reason. And, what made us different this time? And so I think the persistence that is fundamental to this model helped us overcome a lot of that. Some other challenges that we kind of realized is that delivering care in this way on the roadside at kind of various times of the day presented a variety of safety challenges that obviously police officers assisted us with, but a lot of times in the evenings, especially, what we would find is that our targeted client was really inebriated, and there was very little that we could do in the way of providing them case management services. It became more of a crisis intervention, and so we weren't really able to do what we had hoped to do in those moments, and it became more of a medical event, facilitating care to the next level of treatment, be it a hospital emergency room or a detox facility. The timing of services was tricky. A lot of times when we could catch people and they were willing to partake and agree to consent to treatment, a lot of agencies and providing facilities had closed for the day. And so we would have to say, okay, well, I'm really glad that you're interested now. How about we come back tomorrow? We can get some of these forms filled out or these applications done. And then, we'd circle back the next day during business hours and they were gone. And so again, the transient nature kind of became a problem. That said, though, we did a lot to problem solve that. We put officers and clinicians on a variety of shifts to be sure that we had services available throughout the day, to the point where sometimes we got out on the street as early as 7 o'clock before the liquor stores were open, so that we knew that we could catch people before they began consuming alcohol for the day. We provided transportation to treatment facilities when it was required. We kind of adopted the model of, whatever needs to be done will get done. And it seemed to work out pretty well for a handful of folks, which really represents a lot of calls for service. So although there weren't a large volume of folks that we targeted, we really needed to keep the sample size small due to the intensive nature of this work. And I think that's really the only way that it could have been done. I just want to briefly share a success story that came out of this project. There was a client that was actually already known to the Providence Center, but was somebody that was what we would refer to as treatment resistant, very reluctant to engage with us, was not medication compliant, and was known to police officers and had a high incidence of contacts with them because of her homelessness and disruption in the downtown area to a lot of local businesses, kind of general disorderly conduct in cooperation with other transient folks, some substance use issues indicated there. And so when we got started, we weren't really surprised to see her name on this list, but because of, HIPAA and 42 CFR, we weren't really able to share that with police officers until we got her to agree to talk with us. And so because of HIPAA and 42 CFR, what we had to do was develop a script so that police officers would introduce us to these folks and say, we noticed that we have a lot of contacts with you. We work with the Providence Center and we'd like you to speak with them. Are you okay with that? And as long as the client would agree, then there was no violation of protected health information. The client has voluntarily agreed to share their behavioral health needs with police officers at that point, and we're able to engage. And in this case, that's exactly what happened. Of course, she wasn't surprised to see us. She knew us as well as we knew her. But because police introduced us as if we were strangers, she was much more willing to engage with us, because what we found is that the police have actually been doing a really good job taking care of her. Some of them bring her sleeping bags or food. She realized that, she could have been arrested a lot more times than she was. And instead they elected to transport her to the hospital when she was intoxicated versus incarcerating her. And so they had more of a therapeutic relationship with her than we did at that point. And we kind of leaned on that. We tag teamed, and over the course of the grant period, it was really a success of approximations. We had to be very patient and just kind of reframe what was the mission on any given day. We had an apartment for her that she refused to stay in. And I think there was some frustration on the part of the police officers at first, because, for them, they're very solution focused. Well, we have an apartment, why won't you stay in it? And so we had to sort of teach them that there was probably some trauma issues around that, and some resistance, some legitimate mental health issues types resistance that prevented her from staying in that apartment. And so they kind of came around. They became much more tolerant to our therapeutic processes. And they helped us do some systematic desensitization with her. We would spend a few minutes at a time in her apartment with her and then escort her back out. And long story short, she's medication compliant. She receives injectable antipsychotics once a month without any trouble. Much fewer calls for service, police calls for service for this person. She's much less disruptive in the community. I don't think that she's disrupting businesses downtown anymore. I haven't heard any more of that. And she stays in her apartment, and very recently has reconnected with some family members. Her children are back in her life, and she's doing excellent. And I don't think that really that would be the case had it not been for this level of intervention that this grant provided.
Okay, so some of the lessons that we learned early on had to do with the sample size. As Jackie had referenced, these are high touch clients, and we really struggled in the beginning with how many clients there should be. So we initially selected 20, and some people came off the list. Unfortunately, we did have some clients on there that had passed away before we were able to connect with them. And so being fluid and being able to show up to our meetings and make some slight changes to our protocols was definitely necessary. All of us had to be nimble in how we were willing to maneuver and think about the project. And Jackie gave you an example of one great success. There were so many that on paper, if you just looked at numbers, you wouldn't really understand how successful it was. So we're really taking a qualitative approach in our final write-up of sharing some of these stories. And it has been really heart-lifting to see some of these successes. Some of the other things that we learned along the way is that you want to make sure that you have the right police officers and clinicians working together. They haven't always, not this group. I mean, our group has worked together in the past, but sometimes there's some concern from police officers when you have someone from the outside coming in and potentially watching what you're doing, and the clinicians are going to be focused on giving the person help, and sometimes a police officer may actually have to make an arrest if a crime occurs. So you want to make sure that the police understand the role of the clinician and the clinician understands the role of the police officer, and there are going to be some times where each one may have to take a step back and let the other person do their job. As far as COVID goes, it sounds like it's impacted everyone. There was a short gap. Well, it was a couple of, Captain, how long was the gap? About 2 months?
2, a little closer to 3. And we saw some real significance in clients sliding back down.
Yeah, so that was an unfortunate piece to this. The project was going really well. Contacts with the clients were being successful, and then COVID hit. And then as a result of that, clinicians couldn't ride with the police. We had, you couldn't put the client in the police cruiser and transport them for assistance. So, and so there were some setbacks. And then once the project was able to begin again, they started to see some of those successes come back. So as far as the role that Sean and I played, it was really to be supportive of the officers and the clinicians and help identify who these high-risk clients were, as well as to help maneuver around some of the issues that came up as we went. We did attempt to do a lot of documentation since we didn't have such a large sample size that would really lend well to a lot of statistical analyses. We have reports on our successes, and we were also, it was also very important for us to track those who would not come into the program, because we wanted to see where they were, and so we could have some way to compare the clients who chose to come into the program and the successes. And this person we attempted to make contact with several times, they kept refusing, and then what's happened to them. We had officers completing case reports every shift that they worked, documenting how many times they saw someone and what they did. We've done interviews with the clinicians and all of the officers involved in the project to determine what they saw as benefits and places for improvement, as well as recommendations that they have to another department who's considering this type of a project. And we're also going to be doing a survey shortly with members of the Providence Police Department who are outside of this project to see what their take on the project is, in terms of, did they notice an effect and a decrease in calls for service. One of the nice things about having these officers identified as part of this team is that other officers would contact them and say, oh, I saw so-and-so. They've moved corners. This is where they are now. I saw her today and she seemed better. You all are really helping. So it really is great to see these successes and these little wins, because it definitely did have an impact on not only the client's personal lives, but a decrease in the calls for service, at least for the police department.
We did receive one question, which was, what was the process for selecting officers to participate in this program?
We looked for officers who were already inclined to work with this population. Like I said, a lot of our officers already had contact with them. So we made sure we selected officers who already had the skill set necessary and the patience to interact with these clients.
I just wanted to say thank you to all 4 of our SPI sites. We truly appreciate it. For those of you that are attending as new sites, or in your first year of implementation, we hope we gave you some perspective on the range of possibilities available to you as an SPI site. I think we dove into not only some of the operational wins that each of these sites have had over time, but also some of the impact that they're having both on their organizations as well as the criminal justice research field as well.